Cool.
It's now recording.
All right.
I do. Just hold on just a minute.
And you're admitting? Is that what's happening, or people being admitted automatically?
I have it automatically admitted.
Cool. All right. To be axiologically correct, since we are now recording, let's begin. Welcome to session 2 of creating trust-based, patient-centered, anti-racist patient-provider relationships. 4-part series, and this is session 2. We'd like to thank our training sponsors, Trillium, Pacific Source, the Oregon Academy of Family Physicians, AARP, CareWorks, HIV Alliance, the Oregon Health Authority, Oregon Medical Group, and Strong Integrated Behavioral Health. The NAACP is one of the oldest civil rights organizations. It has been said that the civil rights issue for the 21st century is healthcare equity. In this session, our keynote speaker, Dr. Jaya Aysola, MD, Master in Public Health, who's the founder and executive director of Penn Medicine Center for Health Equity Advancement, Assistant Dean of Inclusion and Diversity, and Assistant Professor of Medicine and Pediatrics at the Perelman School of Medicine. Her research focuses on developing and evaluating patient, provider, and system-level interventions to improve care outcomes for marginalized folks, marginalized populations. This work stems from her clinical, administrative, and policy experiences in resource-poor settings. Please welcome Dr. Jaya Aysola.
Thank you, Mark. It's a pleasure to be here with all of you today. Shall we proceed?
Indeed.
Okay. So today I'm just going to review the learning objectives. We hope at the end of this, you'll recognize the difference between healthcare disparities or unequal treatment and health disparities, unequal outcomes, and understand the role of racism in its 3 forms in health equity and inclusion, and identify the patterns of misuse of race in medicine and some recommendations for change and how we incorporate this in our daily practice of medicine. So I'll start out with reviewing health equity semantics and concepts, and then pivot into racism and bias as a root cause for healthcare disparities and health disparities, and then talk about the best practice of use of race and ethnicity in medicine, and then talk about the strategies, sorry about that, for evaluating and addressing disparities in healthcare and health. And if there's time, I have a few examples at the end as well, but I also want to leave time throughout for questions, which is much more important. So feel free to put questions in chat. We'll have the team monitoring them, and we can interrupt my talk at any time. I'm going to turn off my video so I can focus on my slides here, but I'll turn it back on if you have questions. So I always like to begin distinguishing between healthcare disparities and health disparities and talking about the semantics of health equity, because interestingly, we often talk about it in the literature and even in our discourse in ways that sort of conflate these 2 terms. When we think about healthcare disparities, we are thinking about unequal treatment after accounting for equal access to care, patient preferences, and clinical need. And when we're talking about health disparities, we're talking about unequal burden of disease or unequal outcomes. Now, if we eliminate unequal treatment and solve healthcare disparities, we wouldn't necessarily eliminate unequal outcomes or health disparities because of a myriad of factors outside our health system walls that sets the stage for individuals in populations to have unequal opportunities for health and well-being, such as unequal environments, unequal access, unequal resource and opportunities. Often these are called a catch-all term, social determinants of health. But what I'll talk about in the next few slides, as I talk through both healthcare disparities and health disparities, is how the root causes for both of those things are some forms of bias and racism. On the healthcare disparity side, it's institutional bias coupled with unconscious bias. And on the health disparity side, it's structural racism and discrimination that's sort of the antecedent to social determinants of health. So in 2003, there was a landmark report put out by the Institute of Medicine, now called the National Academy of Medicine. And they reviewed over 600 studies in every single field and specialty, subspecialty, and found consistent patterns of unequal treatment, where Black, Indigenous, and people of color, as compared to white patients, were significantly less likely to get poor treatment. One salient example of this was they were less likely to receive adequate pain management for the exact same condition, such as long bone fracture in the emergency room. And they were less likely to be referred, okay, my slides have a mind of its own. It's advancing and I'm not advancing them. They're less likely to be referred for a renal transplant amongst those with end-stage renal disease that desired a transplant when it was clinically indicated. The pain example is a really crucial one. When we think about provider bias in opioid prescribing, when we think about the opioid epidemic today and how it's prevalent mainly amongst white populations, it's actually this provider bias that has set the stage for this to be a disproportionate burden amongst white patients. So why does this occur despite well-intentioned providers operating in a well-intentioned system? This schematic presents the two prevailing theories why this occurs that's posited by the National Academy of Medicine. It's a simplified schematic and it's slightly outdated because they use minority versus non-minority, and I would relabel this BIPOC versus white patients, so BIPOC being Black, Indigenous, people of color versus white patients, or even more broadly, marginalized communities versus non-marginalized communities, if you want to expand beyond just race and ethnicity in terms of disparities in care. But the y-axis is quality of healthcare, and you see a difference. And that difference, once you account for clinical appropriateness, need, and patient preferences, you're still left with a difference. And that's the difference that we call healthcare disparity. So when we think about unequal treatment, we are already accounting for equal access, clinical need, and patient preferences. And once you account for all that, we still see a difference in quality of healthcare. And that's when we call it a healthcare disparity. There's two prevailing theories. The first is the operation of a healthcare system in the legal and regulatory climate. This is what they called it back in 2003. The simplified way of saying this is there's institutional bias baked in the design of our healthcare systems. Why is that? Because historically, they've been designed with a single cultural perspective, that of a white man. And so inadvertently, they've been set up and structurally designed to benefit one population while disadvantaging others. If you couple institutional bias at the macro level with provider bias, most often unconscious biases, stereotyping, and uncertainty, those two forces in conjunction result in unequal care. So Kamara Jones describes these three levels of racism at work, and those two levels are the first two that I talked about here. Institutionalized racism is the ways our societal norms have been structured, where the institutions have been designed in a way that are set up to advantage some over others. Personal mediated racism is sometimes intentional and sometimes conscious, but most of the time unconscious, unintentional, and also includes acts of omission and commission, which is really important to note. And internalized racism, which we didn't talk about there, but we'll talk about a little bit, is what we believe on the inside, what we've all been acculturated to believe. So when we see sometimes that, race concordance or gender concordance between a provider and a patient doesn't necessarily mitigate the bias between the providers, it's because irrespective of our self-identity, we may still have internalized the societal beliefs and societal biases. So I can be a person of color, but I could still be biased against people of color based on the fact that I've been enculturated in the same institutions and the societal norms that makes me think that way. And that's internalized racism. Another catch-all way of saying this, and we often talk about this when we think about gender and women, is imposter syndrome, which is another form of internalized racism. So when we think about institutional bias within the healthcare system, this is a good example. In 2009, that came out. Predictive analytics is a way of us sort of quickly getting to using machine learning and predictive analytics to help us deliver care. And oftentimes there is a risk for predictive analytic models and machine learning to sort of perpetuate current state bias. And this is an example where this did this. And this would be an institutional bias where essentially an algorithm was disproportionately enrolling white patients that were less sick into a chronic disease management program as compared to Black patients that were more sick and probably were better suited for that chronic disease management program. And when they looked at why, they found it was because this algorithm was using cost as a proxy for need. And cost and use as a proxy for need, unfortunately, is a poor proxy because historically we have spent more dollars on white patients that are equally sick as compared to Black patients. So if you use cost as a proxy for use or need, then you can perpetuate disparities in care, which this algorithm did. Correcting that algorithm to use a better indicator for illness solved that disparity, and they were able to more appropriately enroll Black patients into this chronic disease management program. So when you think about institutional bias, that's one system or one healthcare system. When we think about healthcare systems collectively or social systems across society, that's when we think about structural bias. So it's just multiple systems across society. And the RAND experiment in Copays is a great example of structural bias baked in the way we deliver care. The RAND experiment was done in the 1970s to test the idea of copays. It was a randomized controlled trial. It was conducted only in non-Hispanic white patients, and it found that copays curtailed unnecessary use, which was good. They didn't want to have patients overuse the healthcare system. But since that time, in every single study that they've looked, they found mounting evidence that amongst BIPOC patients, that copays are only a blunt instrument and they curtailed necessary use as well. These differences, and I am so sorry, I really don't know why it's doing that. These differences in race and ethnicity and the impacts of cost sharing happen even after adjusting for income. And that's likely explained by differences in wealth. Income does not equate to wealth or accumulative assets. And so when you look at any BIPOC person with the exact same income as a non-Hispanic white person, you have at least a 30% wealth gap. And that's why copays are such a blunt instrument in people of color as compared to white individuals. And they exacerbate and cause disparities in healthcare uptake. So when we think about the micro level, so that's the macro level. If you think about the micro level, how does provider bias manifest in daily care? This was an elegant study done at the University of Pittsburgh. And the reason why I like this study was they used providers as their own case control. They compared a provider only to themselves. So you to yourself and the way you had end of life discussions with your patients in the hospital. And what they found was the providers, there was no difference in verbal communication scores. The providers were saying the exact same things to their patients in terms of end-of-life discussions. However, there were significant differences in nonverbal communication scores as depicted here, with providers more likely to stand at the foot of the bed with white families and patients, engage in eye contact, open arm posturing, and touch. But then with Black families and patients, stand greater than foot of away from the bed, engage in closed arm posturing, lack of touch, and also of avoid eye contact, even though so for their privacy, they've sort of taken away that. But that's what the study did find. And if you contextualize these findings, as these authors do, with the fact that BIPOC families are far more likely to opt for life-sustaining treatments against provider advice, you wonder if these sorts of differences are playing a role. So what do we know in aggregate about bias in the US and its felt effects in healthcare? There's been 2 systematic reviews done to date. The first was in 2017 in emergency medicine only, and they identified 9 qualifying studies out of over 1,000. And all of those studies found an implicit pro-white preference amongst providers when tested. 2 of those studies demonstrated a significant impact of that bias on clinical decision-making. In 2018, they broadened this to other subspecialties, a different set of authors, and they identified 37 qualifying studies out of thousands. 31 found a pro-white bias amongst providers, and 7 of those studies examined the impact of that bias on patient-provider interaction. All 7 found that providers with a strong implicit or unconscious bias demonstrated poor patient-provider communication. And only 2 studies evaluated the impact of that bias on clinical outcomes, and 1 found a difference and another did not. So there's still work to be done in this area, but there is mounting evidence that there is a connection between our unconscious biases and the way we deliver care. So what do we know more broadly about personally mediated internalized racism in the US? If you test the US population at large using the implicit association test or really any other psychological experiment that is able to diagnose your unconscious biases, we find consistently that 75% of the US population has a pro-white anti-Black bias. But 50% of the US population who identify as Black also have that pro-white anti-Black bias. And the healthcare provider biases mirror that of the US population. Bias formation occurs from our cumulative experiences starting in childhood. While gender bias can occur as early as age 3, race-based biases occur as early as age gender bias can occur as early as age 5, race-based bias can occur as early as age 3. And it's really shaped by our worldview and evolving exposures to the culture around us through media, our social community ties, our own ancestry, background, and culture, and our education. So to review, inequality is a healthcare disparity or difference in treatment only after accounting for access to care, patient preferences, and clinical need. A health disparity is a difference in health outcomes or differential burden of disease. And when structural or institutional racism and bias are key contributors to those disparities in health or healthcare, then it is termed an inequity. So what is structural bias and racism again? It's structural policies and practices and structures stemming from historical and social political forces that set the stage for one to advantage one population while disadvantaging another. And I'm going to pause right here to see if there's any questions before I move on to the next few slides, which will set the stage to explain the role of structural bias and racism on social determinants of health and health disparities. Any questions? Okay, I'll move right along. So just as Institutional bias coupled at the macro level, coupled with provider bias, sets the stage for unequal treatment or health disparities. Structural bias coupled with exposure to chronic discrimination sort of sets the stage for unequal outcomes or health disparities. When we think about social determinants of health, health and healthcare are just one of the domains. This schematic presents the WHO's, or the World Health Organization's, conceptual model for social determinants of health. And there's 5 domains: economic stability, education, health and healthcare, neighborhood and built environment, and social community context. And just as within healthcare, you can see macro level forces operating with interpersonal biases, you can see the same thing in the ways in which our educational systems are designed, our economic systems are designed, our neighborhood and built environment, the housing market sets the stage for segregation and unequal opportunities. And we also see this at play in our social community context. One of the key determinants of health that's highlighted in the social and community context by the WHO is exposure to discrimination. And I actually want to talk about this more purposefully here because I think it's often under talked about. Exposure to discrimination impacts our health, and we began to realize this in the late 90s and early 2000s by some seminal work by David Williams and Nancy Krieger, where they started to show that self-reported exposure to discrimination through validated surveys was associated with significant differences in cardiovascular outcomes and in burden of hypertension or high blood pressure between populations, such that the Black population had a higher burden of high blood pressure as compared to their ancestors in Africa, as well as other countries they've migrated to. And no one could quite explain that difference until they started to look at potentially the root cause being exposure to chronic discrimination, and the mechanism of being that chronic stress that results from that raises your cortisol levels over time and has a consistent wear and tear on your body. And they started to wonder whether that would explain the stark differences between Black and white women in poor birth outcomes, specifically preterm birth and low birth weight, because those differences were so striking and couldn't be explained by education, income, or any other socioeconomic status variable. Specifically, and more shockingly, what they knew was a Black woman at the highest income bracket with a professional degree, an MD or a JD, had a higher risk for poor birth outcomes than a white woman at the lowest income bracket with less than a high school diploma. And they just couldn't explain why. And so in 2006, Lauderdale did a really elegant study that actually capitalized over a tragedy in the US that created a newly discriminated group. And they compared birth outcomes by race, ethnicity, and nativity for women who gave birth in the 6 months pre-post 9/11. And what they found was the relative risk of poor birth outcomes was significantly elevated for Arabic named women only, and not for any other group, suggesting not only the role that exposure of discrimination could play, but how quickly it could change the biology of a population at the population level in only 6 months' time. So how does this work? When we think about structural racism as an antecedent for social determinants of health, we think about the social systems here, and then structural discrimination, then enacting the tools, the laws, the policies, the structures, the decisions, the regulatory environments that start to create bias within our social systems that impact our health. I talked about one of those structures and policies in medicine and healthcare, such as copays and cost sharing, that creates unequal uptake of healthcare between white and non-white populations, and showed how it impacts healthcare in that way. Well, we can see the exact same ways other sorts of policies can impact our health. For example, discriminatory policies such as mortgage discrimination, redlining, and zoning has created residential segregation. And through that, differences in quality of housing and neighborhoods, risk for environmental exposures, food deserts and lack of green space, unequal opportunities to education and employment, all through policies and housing that sets the stage for one group in our society to really not benefit from full access to everything possible to ensure that that population is thriving in a way that mitigates their health disparities and creates well-being within that population. And if you think about the roles in just this sector, there's recent examples even today. If you think about the recent event in Flint with the water crisis, that was a government policy alone that created a catastrophe in Flint that resulted in significant health disparities in BIPOC children, primarily in Flint, for years to come. This is another schematic that can show how this operates. And there's different ways of looking at it. But again, your social systems are here, how racism works through our laws and policies, and then it results in outcomes. So I'm going to pause here. So now we've gone through all of that. So this is a lot to take in. So how do we sort of dismantle this in medicine? And I'm going to talk about strategic approaches, starting with the use of race and measurement and how we apply a system deficit approach. And then I'm going to end with how we sort of apply this one-on-one through the act of cultural humility. But I'm going to pause in case there's questions or comments. Okay, I will move right along, but please don't be shy. So we looked at how race plays a role in the way we train our providers, because the way we use race in medicine has set the stage to perpetuate provider bias. And it's one of those ways in which structural and institutional racism function. So our design of our healthcare system has two parts. It's the way we operationalize our healthcare system. Copays was a good example, but it's also the way we generate our medical science and impart our medical knowledge. And this is a great example of how do we really rethink the way we think about race in the way we generate medical science and the way we impart medical science to each other as a way of getting at some of the root causes of structural bias as well as provider bias. So the premise of this is that race is not a biomedical term, yet we continue to use it as such. There's no biological basis for race. There is, in fact, more genetic variation within one race than between two races. It is actually a social construct that is based on one or two phenotypic characteristics, primarily our skin color or in our hair texture, perhaps our nose length and our eye shape. But frankly, those are not holistic and they do not represent genetic makeup, as evidenced by the fact that there's, again, more genetic variation within one group of the same race than between races. And it's defined differently by different countries. And the categories of race have evolved over time, even within the US, almost every decade since our inception. And so what we did with this study is to analyze our UME or undergraduate medical curricula for the use of race. And we found 5 key themes or patterns by which race is misused. And I'm going to walk through these 5 with salient examples to talk about how we can improve. So the first is how we just talk about race. We continue to use antiquated terms such as Caucasian, and we also use imprecise labels such as African American to describe anyone with African ancestry without regard to differences between first and second generation immigrants from the Caribbean or Africa, or those whose ancestors were actually enslaved in the United States. We also use ethnicity incorrectly. Ethnicity refers to social groupings that are based on some combination of shared language, history, religion, and or culture. But yet we use Hispanic as the only ethnicity that's sort of akin to the government constructed categories of race, but not consistent with biological differences. And unfortunately, we use both race and ethnicity as proxies for ancestry and genetic predisposition, but yet they are not. So we inconsistently use social labels such as African American, Hispanic, or Black to convey biological differences, but these are not biological categories, yet we continue to do this in medicine. So what are the standards and the best practice for using race and ethnicity and language in our field? The Institute of Medicine in 2009 actually spelled out the way they want us to use race and ethnicity and language in medicine, yet our uptake of this has been poor throughout. What even despite encouragement from national agencies such as the Institute of Healthcare Improvement, CMS, and ARC, urging us as healthcare institutions to adopt best practice in the use of race. I'm going to walk through the best practice in the use of race, ethnicity, and ancestry. I'm going to leave language out for the moment here. So what we want to do is collect real data appropriately. So our traditional way of collecting race data stems from the Office of Management Bureau categories, or the OMB categories, which has two questions. What is your race? And it doesn't include Hispanic. And what is your ethnicity? Hispanic versus non-Hispanic. The best practice is to have a single question that describes both race and ethnicity, because ethnicity and race combined are both social constructs, and race alone is not a biological construct, and neither are biomedical terms. And then to allow everyone to select one or more options to identify multiracial and ethnic individuals in our society as well. And that is the recommendation that we hope you can sort of institute in EHR as well as in your health systems and in our research. Traditionally, again, OMB only asks about Hispanic and not any other ethnicity. So you can't distinguish between any Asians, Indian, Chinese, or Lao. You can't distinguish between someone who's Black but from Nigeria versus descendant of slaves from America. You cannot identify anyone from the Middle East because they have no category. So they also recommend a single question to capture one's granular ethnicity or ancestry. This is really akin to one's country of origin. And they recommend a few ways of asking this, and to use a locally relevant list from a national standard set, which is way too long to show you because it pretty much lists every country possible. So the other misuse of race ethnicity beyond semantics is that we often talk about racial and ethnic differences in disease burden and outcomes of disease without discussion of causal factors. And so assumptions are made about genetic predisposition rather than other contributing factors. So when we think about health disparities, we really want to examine the context. So if you see a difference in diabetes, you see a difference in high blood pressure, you want to ask, what are the migration patterns of this population? And is this difference seen in the US only for this population compared to their ancestors from origin countries or other countries they've migrated to? And what are perhaps the social, environmental, historical, and political factors that are contributing to the differences that we're seeing? So that's the recommendation. To give you an example of a common misuse that illustrates this is that of Pima Indians. I think for those of us in medicine, Pima Indians are often synonymous with type 2 diabetes. That's what we were learned. That's what we were taught. And it's sort of a knee jerk to think about them when we think about type 2 diabetes. What we don't know about them is that they were river people. Pima means river, from the Gila River. They were master water engineers. And really in the early 1900s, they only had one documented case of diabetes amongst them. But from the 1950s onwards, they had the highest rates of type 2 diabetes in the world. Yet these patterns were only seen in the US Pima and not the Mexican Pima. And they were subject, because of this, to decades of genetic research. And in the end, the the expert in the field that had done the majority of research and led the majority of genetic research, and then came out with the seminal conclusion that there wasn't a genetic link that could explain this disparity. So what was happening? What happened? In 1930, the Gila and Roosevelt dams were built. They cut off the only water supply and only source of food and economy to the Pima. The US military was then forced to provide commodity foods, which was free foods, and it was surplus food in the forms of white flour, cheese, refined sugar, lard, and canned goods. In 1996 was the first time they introduced fresh produce into this food commodity program. As Dr. Donald Warren says in the PBS special series, Unnatural Causes, when you think about the traditional American Indian food, for example, fried bread is one of the things that comes to mind. Well, in truth, the tribes did not have fried bread historically. The roots of the fried bread program are in the commodity food program. And a fried bread is essentially trying to do the best you can with your commodities. Flour, lard, vegetable shortening. Over generations, people grow up with that and it becomes part of the culture. It becomes acculturated into the community. It becomes part of the norm. It's really this historical insult and not any sort of genetic predisposition that set the stage for the US Pima to have the highest rates of type 2 diabetes in the world. Race-based diagnostic bias is the next error we sometimes make. And this is because even when we have a higher prevalence of certain conditions by race, we tend to think about it as race being the intrinsic cause to that disease rather than some natural antecedent. For example, with cystic fibrosis, which is predominantly seen in Northern Europeans and white children, if we think of that disease as intrinsic to whiteness rather than related to a selective protective effect of chloride channels in a northern climate in Europe, then we are going to miss the times in which we see it in another population, as illustrated by this case here, where it took until age 8 to diagnose a Black child with CF, and only by a radiologist who was blinded to her race and just saw her CT scan and asked, who's the child with cystic fibrosis? Another example of this is sickle cell anemia and malaria. We often think about sickle cell as exclusively prevalent in Black patients alone. And something, if we don't recognize that this is not intrinsic to their Blackness, but rather the sickle cell trait is a protective developed in malaria endemic countries because it's slightly protective against malaria, we would not realize that it's seen in a broad swath of countries where malaria is endemic, and we may miss it in other populations. Pathologizing race is one of the other things we do in addition to race-based diagnostic bias and race-based discussing race without prevalence. And this is where we tend to highlight pathology exclusively amongst BIPOC populations. We see this when we talk about race and ethnicity adjusted life expectancy. When we talk about this without context, it leads someone to sort of equate race rather than structural racism with early death without explanation. So when we say that race, when we talk about early mortality and morbidity in race in populations that are BIPOC, without explanation, without context, we are pathologizing race. We are saying there's something intrinsic to that race that's somehow setting the stage for early death, when in fact it's actually racism and not race that's often causing early death. We see this with COVID-19 and race and ethnicity. How we discuss COVID-19 often stigmatizes certain populations. We see this with the selective discussion of vaccine hesitancy in certain populations. interestingly and notably, right now, when you look at the highest rates of vaccine hesitancy amongst white Republicans, yet that is because the reasons for their vaccine hesitancy are actually immutable. They're static. When surveyed in December of last year, the reasons amongst that group of individuals was they didn't believe in the virus itself. But when you surveyed BIPOC patients and BIPOC populations in December and then later in February, their reasons were mitigated over time. They were dynamic. The predominant reasons why there's hesitancy amongst BIPOC communities was they were concerned about the newness of the vaccine. They were concerned whether they were tested in diverse communities. They were concerned about the side effects and whether they knew about the side effects in diverse communities. And time took care of a lot of those vaccine hesitancy reasons. And so again, talking about differences in populations without understanding the root causes for those differences creates biases, and understanding root causes helps us mitigate those biases and not pathologize one group over another. The result of using race incorrectly in medicine, not only when we talk about race in our discourse and in our dialogues and in our literature, and also in the way we impart our medical science, is we also create the next cadre of physician scientists who then use race incorrectly in their science. And that results in race-based guidelines, which is the last error in our use of race. So it's a natural consequence of using race wrong in all the ways I've talked about earlier. Race, again, is a poor proxy for genetic predisposition, yet it's still operationalized as a biomedical category. And therefore, we see the persistence of race-based guidelines. I think the most famous one is the way that we correct for renal filtration rates, where we have a race correction factor, which raises the threshold for concern exclusively for Black patients only, and actually can exacerbate the underlying renal transplant disparities I talked about earlier in my talk. Other examples of this is high blood pressure guidelines and pediatric UTI guidelines, but there's many more. But I'm going to use the kidney example to just illustrate this case with these twins here, but how challenging it is to operationalize race-based guidelines. So here you have twins with one Black parent and one white parent, and they would self-identify differently in our society, and they would be perceived differently in our society. So with the exact same creatinine of 1.3, the white sister would have a GFR of would have a GFR that would qualify her for a renal transplant, and she'd be referred. And the Black sister would have a GFR that wouldn't refer her to a transplant. And say they both identify as mixed race, the physician's left with an arbitrary decision. They just have to pick between a binary race-based guideline and decide where they want to fall when they operationalize this guideline. And that's how challenging these guidelines are in practice, yet the remnants of them are still in medicine today. So what are our recommendations moving forward? The first is to standardize the way we use language, and to do so the way the Institute of Medicine or National Academy of Medicine put out in 2009. The next is for us to always remember to contextualize our racial and ethnic differences that we see in disease burden appropriately. So when we see differences in disease burden, when we see differences in outcomes, we want to know about those differences by granular ethnicity or ancestry. We want to know about those differences as it relates to migration patterns. We want to know about those differences as it relates to structural racism and antecedents. That sets the stage for different exposures to societal structures and determinants of health. And then we want to generate and impart our evidence-based medical knowledge when it comes to race. So we have a long ways to go before we change the paradigm but of the ways we talk about race in medicine. But at the very least, right now, we can apply greater scrutiny over the science we read so we can do it right and think about the ways we're talking about race and race-based science in our discourse with ourselves as colleagues and even with our patients when we're thinking about that. I'm going to pause before I go to the next slide, which talks about measurement in case there's questions. And I
There
also
are questions.
yes, yes, good, good, good. You should have interrupted me.
They have been piling up.
Okay, let's talk.
Oddly enough, you have answered the first one, but I'm going to read it anyway.
Yep.
Do you have any insight into medical lab results and racial bias, such as kidney function tests?
Yes, yes. And I did just answer that. So, I think there's been a national movement to eliminate race-based correction for renal function. We have already eliminated, I think it's on its way. So at Penn, we have pushed to eliminate it and it's going to be eliminated. They're working on the labs right now. We've already eliminated it for referrals to transplant because we want to mitigate that disparity right now. We don't want to wait. But several medical systems have already operationalized that. Also, several medical systems, ours included, have operationalized the appropriate collection of real data as well. And so there is a movement towards this, but it's going to take, it's going to take a while. If you think about broader industries, we have yet to sort of adopt the metric system in our businesses, in our factories. So sometimes it just takes a little bit of time, but the movement is there now.
Can you say more about racial concordance between healthcare providers and patient and how that doesn't really improve outcomes?
Yeah. So to say it doesn't really would be sort of overstating the science in this space. It's mixed. Just as you saw from what I talked about in terms of, internalized racism, internalized bias, again, 50% of those that self-identify as Black also have a pro-white, anti-Black bias. 75% of individuals in our society that identify as male and female, so 75% that identify as female also have a pro-male, anti-female bias. So you can see how strong the female internalized bias is, where it's even stronger than the race-based bias. So what we know is that race and gender concordance can help sometimes, but we have a mixed bag because we all are still operating under structures that are intrinsically designed still to set the stage for unequal care. For example, irrespective of your unconscious bias, copays still exist. Irrespective of your unconscious bias, we still have race-based guidelines. So, you have to fix the structure and not just diversifying the workforce. But this is not a reason not to diversify the workforce. And that's a really important caveat. What this means is not only do we need to diversify as a strategy the workforce on the front lines, but we need to diversify the workforce throughout all levels of the organization. Because once we get to a diverse perspective, designing the healthcare models of tomorrow and generating the science of tomorrow, then we start to mitigate our structural bias and our institutional bias. So diversity matters, but it matters all the way up.
There was this, you also probably just answered this next question. How do we begin to dismantle this beyond our individual person?
Yeah, and I'm going to get at that in the next few slides. So I may put a pin on that a little bit, and I'll see if there's other questions, because I feel like that's my strategies in terms of measurement and taking a system deficit approach is going to get at some of that.
Let's see. Maybe I don't quite get what you mean by biomedical term.
A biomedical term is race and gender actually are both misused as biomedical terms. Sex is a biomedical term. Sex at birth is a biomedical term, but gender identity and race are not. They're societal constructs. So they've been constructed by society. They do not reflect biology, yet we continue to use them in that way. And that's what I meant by that. So in our science, we use them as biomedical terms and we talk about race-based differences in disease when we really should be talking about ancestral differences in disease. And what using race as a biomedical term does for us, it allows us to sort of mitigate or hide behind some of the true factors, because what's really at play is not innate differences between us by race, because like I said, when you look at genetic variation within one race, it's actually there's more genetic variation within the race of Black than between Black and white people. So it's definitely not about genetics and biology, but it is about the experience of racism in society. And so it's racism that explains differences. Yet, if we continue to use race as a biomedical term, we can't get to that greater truth.
There is a link in the chat to a book, Unnatural Causes. Everybody can.
That's the PBS, yes.
Yeah.
That's the PBS special I talked about. And Dr. Warren actually went to the same, he's alumni of the same fellowship that I attended, and he's featured in that when he talks about the Pima Indians. Yes, it's a great series. I highly recommend it. Shall I move on, or
Sure.
and we'll get to some of the rest? Yeah,
Yeah.
we're gonna have a lot of time at the end too, but I don't, if there's burning other ones, I don't want to stop for sure. I could.
Yeah, there was one about sickle cell, but you answered it. Basically, it's exposure to malaria, not just a Black.
Malaria, yes. Yeah, so sickle cell trait is a great example of Mendelian genetics, right? So you can have like you can have one allele, which gives you a partial manifestation of disease, or you can have two alleles, which gives you the full manifestation of disease. But when you have just the trait or one allele, it actually confers a little bit of protection against malaria in endemic countries, and that's why you see it prevalent in not just Africa, but also in India, in the Middle East, etc. So addressing equity begins with measurement. We're not going to get this right until we start to identify the problem. And so we talked about the ways to better collect your data within your healthcare system, but then you have to take all of your performance metrics and all of the ways in which you grade yourself on performance and begin to stratify that by demographics, and to look at your performance and your quality of care by race and ethnicity and other demographics to identify disparities, learn how to present that in equity dashboards for key metrics of interest, and then begin to develop the infrastructure that leverages quality improvement techniques to routinely address those disparities that you identify. So how does that work? The other thing I want to say in terms of measurement before I pivot to patient care measurement and applying QI is when we talk about structural racism, people wonder, well, how do you measure that? Like, how can we measure that? And there are some ways in which people have discussed measuring it. When we think about area or neighborhood deprivation indices, that is more of a measure of social determinants of health. And remember, social determinants of health doesn't have a valence. That's really important to recall. We all have social determinants of health. We all have social factors that impact our health. Some of us have it in a way that sets the stage for us to benefit from the social structures around us. And some of us have it set up in a way that we don't get to benefit from it, but there's no valence to social determinants of health. So how do you then go and measure something that's an antecedent to that? A couple ways of doing it is to think about the policies that creates racial segregation in housing. Housing is a really common way. Owning a house is one of the huge assets. When we talk about wealth gaps, we talk that accumulated wealth gaps, home ownership is one of those contributing factors. Racial segregation sets the stage for a myriad of factors that impacts our health. So looking at the black-white odds of denial of mortgage application is one way of measuring structural racism. Looking at political participation, the ratio of Black and whites elected to the county board of supervisors. Looking at judicial treatment, the ratio of Black and whites incarcerated for the exact same felony. Those are ways in which you can begin to measure structural racism if you're interested in researching this more so than operationalizing it. But how do you operationalize this? Like in your daily practice, in your systems, when you're thinking about dashboards, when you're thinking about your panel of patients, when you're thinking about quality improvement interventions, whether you measure it or not, it's important to know that every quality improvement intervention has one of three possible equity outcomes when it improves subgroup quality as well as aggregate quality. So if you start out with an underlying baseline difference between a marginalized group and another group, and you institute an intervention and you use run charts like this to track it over time, that intervention can either widen the gap between two groups, even though it improved the quality for both groups. So, the idea that, a tide gets, what's that? I forgot that adage, a tide raises all boats, but whatever it is, it doesn't with equity. As depicted here, it can widen the gap, but improve it for each group. It can sustain the gap, or it can eliminate it. The vast majority of quality improvement interventions merely sustain the gap. So you improve outcomes for both groups if you have an underlying disparity, but you don't narrow that disparity. The public health campaigns are great examples, sadly, of interventions that have actually widened the gap over time between groups. And good examples of sort of interventions that can narrow the gaps lie in behavioral economics. How do you take the burden off of a population to improve? How do you put iodine in salt for goiters? You put fluoride in water. You take for pediatric burns, instead of having the tip sheets where you tell parents to take their water heater and put it at the lowest setting, you institute a policy that says all water heaters come out of the factory at the lowest water heater setting. Or for aspirin for heart attacks, you institute a knee-jerk protocolized system within your EPIC that gives everyone an aspirin that presents with a heart attack. That has stopped disparities in aspirin for MIs across the nation, just protocolizing it. So there are ways of eliminating gaps while improving aggregate quality and subgroup quality. Even if you don't have a baseline disparity, it is still important to measure your improvements over time, because your intervention can actually introduce a disparity. So if there wasn't a disparity, you could actually cause one later, as some of the breast cancer treatments have done. So strategic interventions often follow QI principles with an equity lens. Again, it really starts with defining the problem. For those of you in the QI space, you will know this, but you want to define it by stratification. You want to define it by stratifying your metrics so you can know what the differences are by race and ethnicity. And you want to ask yourself, is this unequal treatment or a process measure, or is this unequal outcomes or unequal burden of disease? If unequal treatment, what are the causes or root causes? Is it provider factors? Is it system factors? If it's unequal outcomes, is it due to unequal processes, access, or other social determinants of health? And then you want to develop countermeasures and interventions, but you want to do so with a systems deficit lens and not a population deficit approach. I'm going to talk about what I mean by that. And you want to vet those ideas from the onset and develop it from the onset with a diverse set of stakeholders. And then when you engage in an iterative process of quality improvement through plan, do, study, act cycles, you want to track those outcomes by race and ethnicity so you can monitor whether disparities are reduced, sustained, or widened. So what do I mean by applying a system deficit lens to our interventions? I love this coin model because it really helps me illustrate this point. If your coin is a system inequality or a social structure that maintains inequality, actually inequity here, you can have on top of the coin a population that is privileged by that system. They did not earn that. They have it because of who they happen to be, and they have a selective advantage over others. At the bottom of the coin, you have a population that is disadvantaged by that system of inequity. They also did not earn it. They have it because of who they appear to be, and it systematically disadvantages them. And when we apply an intervention, we must be asking ourselves, do we want to address the system or social structure that's created this inequity? Or do we want to look at the population that has a disadvantage and say, oh, woe is me, what's wrong with this population? Is it unfortunate circumstances? Is it genetic predisposition? Is it lack of personal agency? The truth is, it's none of those things. It's a system of inequity, and they did not earn it. It's nothing intrinsic to them. And so our intervention system needs to reflect that understanding. Yet, as simple as that is, it is really hard for us to do. And many of our interventions do not reflect that understanding. And so to take you through that with this really simple schematic, I'm going to start with inequality. So say here we have the goal of getting someone an apple. The apple is our care treatment. And inequality is, you can see here that there is differential access to that apple. One person is able to get that apple, another is not. It's unequal. Equality or equal care and eliminating that healthcare disparity would be getting someone equal tools, an equal height ladder, but it doesn't solve the problem. So you can give someone standard high quality care, which is an important part of this. We want to give equal high standard quality care, but in every instance, that's not enough. It's a starting point, but that's not enough because we don't achieve the goal of the apple. So what about equity? So we customize our tool, right? And so we raise the ladder for one group and we achieve our end. This person, everyone's able to get the apple. But what we've done here is a population deficit approach. We have fixed this problem for this population by giving them a higher ladder, which assumes there's something intrinsically wrong with them. They need a higher ladder, which is true. They do need a higher ladder. But a system deficit lens says, I'm going to, in the justice column, fix the tree. I'm going to fix the tree. I'm going to straighten the tree where every care intervention that I give will be equitably applied, equally applied with equal outcomes. I'm fixing the system. That's the difference. So when we think about interventions such as patient navigators, such as community health workers, which are wonderful interventions, and by no means do I want to be disparaging of them, they are helping patients and populations navigate a broken system for better access to care. But how do we fix the system? It is not by layering enhanced personnel on top of the system to help patients navigate. It is about how do we get our workforce that is more diverse, that reflects the population that we're treating. How do we get a diverse workforce that is culturally humble, that's culturally effective, that knows how to apply equitable care? How do we rid our systems of the baked-in inequities? Those are the interventions that take a system deficit lens rather than a population deficit lens. I'm going to pause here. The next few slides are talking about cultural humility in workforce and why that matters, but I do want to leave time for questions again. Any burning questions?
Yeah, I have a question. I was curious on that slide where you showed public health initiatives widening the gap.
Yeah.
Kind of in, breast cancer, I just, or like smoking cessation, if you could use that as an example of how that widened the gap.
Yes. The public campaigns of the past, were educational campaigns that were really designed to target certain groups, as well as they were coupled with regulatory requirements, especially with smoking, that again target one group to eliminate that disparity. For example, we eliminated we had all sorts of tobacco regulation, but we didn't eliminate menthol or sort of flavored cigarettes, which disproportionately are uptook by BIPOC populations, Black communities. So there's regulatory policies that we did, as well as educational public health campaigns that were interventions that really were designed to help white people stop smoking. And we saw the impact of that. Anything else? I have a few more slides, so maybe I'll just finish and then we can, and I also have some examples and I'm happy to walk through an example too. So however you feel, but when we think about diversifying our workforce as a intervention, we spend a lot of time at Penn measuring inclusion because the way we treat each other actually impacts the way we care for our patients. And a healthcare workforce is sort of a social system that is biased just like any other system, where we see unequal advancement, unequal recruitment, unequal evaluations. We see microaggressions and overt discrimination. We see weaponization of professionalism and the impact of wellness. So even when we recruit diverse candidates within our health system, they do not rise to the top. Recruitment is only as good as advancement and retention measures that are in place. Otherwise, it's a revolving door. We often focus on pipeline, which is important, but again, it's a population deficit intervention. We actually have a lot of highly qualified BIPOC students applying to medical schools. That is not the only deficit. We see a structural bias in who's interviewed and then who's eventually offered a spot that we have to address as well. So how do you take all of this and then sort of bring it to, how do you apply cultural humility and think about anti-racism? It starts by understanding what anti-racism means. Anti-racism is not being racist. Being racist is not the same thing as being anti-racist. Being anti-racist is understanding those forms of racism that we were talking about, knowing that most of us don't have explicit interpersonal racism or conscious racism. We operate with unconscious biases in a very biased system. And so being anti-racist is understanding that we must be proactive in examining and dismantling the policies, practices, and systems at play that create opportunity for some but disenfranchise others. And then we have to understand what the root causes are for the differences that we're seeing between people and go a little bit deeper and first ask, not what's wrong with this person or population, but rather what's wrong with the system or the provider. And we want to approach each other with cultural humility rather than cultural competency. So cultural humility asks us to develop a set of tools to approach any patient, irrespective of their background, rather than memorize a set of stereotypes, if you will, of minority cultures. When we think about cultural humility, we have to think that all populations have culture, and culture is with every interaction, not just with certain groups. And so every interaction we have, be it with each other as colleagues, or be it with our patients, is a negotiation between two worldviews, yours and the person. person. And this should be an alternative framework to both cultural competency, but also to terms we often use in our chart, which perpetuate bias, which is non-compliance and non-adherence. When we put those terms in a chart, they are non-starters. The next person that sees that chart doesn't elicit why that patient may not be taking the care we prescribe. It ends the conversation. So rather than use those terms, just ask why. I see you not taking this treatment. Can you tell me a little bit more about why so I can understand? Can you tell me about what the barriers may be so I can document those barriers? Another word we hide behind is literacy or poor literacy. That also ends up perpetuating bias within our charts, because the next provider is like, this patient won't understand. I won't take the extra time to explain it to them. Whereas maybe the next provider could explain it to them in a way that you were unable to. And so what we know about literacy and health literacy, when you test the US Society, when you test all US adults with a 5th grade reading level or more, only 12% of them are health proficient. That means only 12% of our US adult society with a 5th grade reading level have the numeracy, navigational skills, and literacy skills to effectively interface with our healthcare system. So if 88% of the population does not have those skills, the problem is not the population or a given patient, the problem is the system. And so using the word poor literacy is poor health literacy, I think perpetuates our biases and prevents us from getting to a greater truth. So you ask yourself, what is your story and how does it impact your views? And consider what perhaps is their story and what impacts their views. Cultural humility is about self-reflection. It's about looking at your assumptions, what biases you have based on past experiences or culture that you bring into each culture, to each encounter. When you are uncertain, do you just ask someone or do you assume? It's also applying a certain degree of scrutiny over the signs you read. How is this knowledge generated? Who sponsored this knowledge? Is it isolated to specific cultures or time periods? And it means applying scrutiny over your processes. What structures and systems are in place that may lead me to apply preferential treatment or selection to some over others? And are patients being treated the same regardless of background or culture? And you don't assume that. You can ask if you have Epic or use electronic health records. You can use Slicer and Dicer. You can look at your panel of patients and start to look at it by race and ethnicity and see, is my care equitable? Is my care equal? And so with that, it's the end. I know we have another like 10, 15 minutes for questions if there's more. I also have a couple examples that I can give, but it's totally up to you. The time is yours.
There's a question in the chat about what you think about cultural competency training. I want to add a semi-personal note in that people who have asked questions about their care have been written up in the chart as non-compliant because they ask questions about their care, especially if they're minority.
Yeah.
I don't know if I have a scientific study to back that up, but that has happened with several people of color I've talked with in terms of getting a reputation for being non-compliant for asking questions.
Yeah, for trying to be your own advocate. Yes. And I think that's really important that we encourage patients to ask a lot of questions, because it is not a perfect science that we peddle in our offices. And, medicine's constantly evolving. We're going to have to evolve again to rid ourselves of some of the paradigms that set the stage for inequity in our health system. So, the more questions patients ask, the better. It keeps us honest. So cultural competency training, we do, societies regulate it, but we just changed the word. So the recommendation now is, although a lot of the agencies may not have fully retermed it, a lot of the agencies have taken out the term competency and put in humility. But until then, when you have your modules within a health system, et cetera, we engage in cultural humility training and unconscious bias training at Penn. And we have modules that I can share with the group to talk about that. The reason is sort of easy. There's no, the migration away from cultural competence was this understanding that no one can really be a competent in a culture other than their own, and cultures aren't monolithic or static. They evolve in time. So if I know me as a Southeast Asian, as an Indian American, like if I thought I was culturally competent and I could treat all Indians because of that, I would be greatly mistaken. Everyone's different. We're not monoliths. And it also assumes, the old way of training assumes that there are only minority cultures, whereas we all have culture. Everyone has culture. And so cultural humility is like, rather than memorizing a set of stereotypes of minority cultures, realizing that we all bring something to an encounter. And each encounter is figuring out the biases and the baggage in our culture that we bring, and the baggages and bias and culture that they bring, and negotiating and figuring out a shared worldview between those two. And that's the culturally humble set of tools that we want people to have.
What are methods we can use to train the staff of our medical units to have more cultural humility? Are there specific trainings available? I find that it's hard to get all staff on board with this, especially the ones who need it the most.
Yeah. There's a lot of good unconscious bias training work and modules developed. We ended up developing our own at Penn, but there are some off the shelf ones. I will look and send some links to the organizers afterwards to make sure you get that. But there are some resources as well in Disparities Solution Center. I'll also provide the link to our center. So we have some resources there as well that you can pull from, so to sort of create your own sort of package. I think a facilitated session is what we've been doing most recently. And there's, Howard Ross, the company, if you can afford it, they do have facilitators. They're somewhat expensive, which is why we ended up doing our own after a while. But there are groups that do those facilitated trainings. There's also Uche Blackstock, who is a ED physician and a colleague and friend of mine, who also will come and do personalized trainings as well for a team or a staff, et cetera. And she has a website as well.
Let's see. What is your time like, doctor? We actually are at time for what we've stated before, an hour and 15 minutes.
I can go another 10 because I think I postponed my thing till 4:30, my next workshop. So, and I do have, I don't know if this is helpful. I do have one example on prostate cancer that I can give to kind of synthesize how to think through a condition. If it's not, don't worry. We can just use it for Q&A, whatever you guys want. It's your time. I see a thumbs up.
Yeah, let's do the example.
Let's do the examples. Okay. So I love this this picture here, because I think what it illustrates is where we are with medicine in thinking about the genetics versus the social determinants and the structural determinants as root causes for differences in disease. We have everyone sort of working in their own silos thinking it is what it is. So you have a lot of genetic research looking at the differences by race and working on that. And you have a lot of people in the ecological space or social scientists like myself that are looking at it in terms of structural determinants. And so I wanted to see, well, how do we put this together? If we think about prostate cancer, this is the example I choose to use. So this is what we know. In the US, men that self-identify as African-American or Black as compared to white have a 1.5 times greater chance of developing prostate cancer and are almost a little over 2 times more likely to die from the disease. These are health disparities, right? So a greater burden of disease as well as worse health outcomes. So that's that term. But we also see that they suffer significant healthcare disparities. So in the 30 years of unequal treatment for prostate cancer of the same, we have well-documented in over a 30-year span, unequal treatment for prostate cancer of the same severity by race and ethnicity. So Black patients as compared to white men are less likely to receive definitive treatment, and the disparity is actually widened with increasing disease severity. They're less likely to receive radical prostatectomy and pelvic node dissection when indicated, and there's no evidence of greater comorbidities or contraindications that is the reason for not getting that definitive treatment. And the established benefit of definitive treatment on cancer survival for Black men is there, yet they continue to get, there continues to be disparities in care for prostate cancer amongst men. We see also not just underuse of definitive treatment, but also overuse. So when we think about healthcare disparities, I didn't talk about this in this lecture, but we have to ask ourselves, is the difference clinically meaningful when we see unequal treatment? And also, is it underuse of a needed treatment, or is it overuse of a not needed treatment? And we actually see both with prostate cancer in Black men. So you see them reclassified, the reclassification rates of very low risk cancer in Black men are higher than white men while still exhibiting pathological symptoms post-radical prostatectomy. So there's evidence that they're also misclassified and sort of underclassified, as overclassified as higher risk, but yet they suffer from less definitive treatment. We also see double disparities in care. So these are two types of healthcare disparities. So you have treatment at a minority serving hospital. Predominantly, minority serving hospital was associated with lower odds of receiving definitive treatment and a longer time to definitive treatment for high-risk prostate cancer patients, despite adjustment for race. And then after you account for all these factors, also most facilities within the facility favored definitive treatment for white patients. So you see two things at play. You see hospitals that are under-resourced that service BIPOC populations at greater than 50% have worse outcomes than the hospitals that service white patients in the majority. But within hospitals, you also see a disparity. So you have a site-based disparity and a within-site disparity. And when we evaluate the role of healthcare disparities for differences in mortality, several experts in the field have found that the regional disparities in definitive treatment actually mirror the regional disparities in mortality. So they actually believe that unequal care is what is causing unequal outcomes. But what about the greater burden of disease? That's not seen there. So the highest rates in the US and Caribbean, so there are higher rates in the US and Caribbean as compared to ancestors in Africa. So that's what we know about prostate cancer incidence. For example, as compared to Nigerian men, African-American men are 10 times more likely to develop prostate cancer. There are hereditary factors that people talk about, and there's a lot of studies that have looked at genetics about this, and they do find that prostate cancer can run in families, but most prostate cancer occurs in men without a family history, so it's not ancestry that is explaining this. And when we look at defined factors contributing to genetic risk, they can be defined into two main categories: the very rare ones, which is a high penetrance and low prevalence, so that you don't see those really rare genes like BRCA1 and 2 or Lynch syndrome amongst African-American men that explain this. But you see the more common variants like SNPs may be more prevalent, but again, those confer very modest increases in risk. So there's really not a good genetic link here. And while there's not enough studies examining the role of structural racism in prostate cancer incidence, the few that look at it have shown some link in self-reported discrimination in prostate cancer. So that's sort of putting that all together when you think about one condition and how nuanced it can be and how complex it can be to understand. Should I do a second example in the remaining time, or do you want me to pause for questions?
This is
Yeah, go ahead.
Jeannie. Hi, this is Jeannie Savage, and I just wonder from what you said before, how much of the lack of definitive treatment in prostate cancer is really about the provider-patient relationship. And when you're guiding somebody through that treatment, if you have a very engaged and genuine, humble relationship with that patient, and you really have a strong feeling of something that could be good for them, many times when you have those relationships, your patients are much more likely to follow through with that treatment. So I wonder, because of those fractured relationships, and because we don't build those relationships, as you said before, with our BIPOC or our Black population, are they not getting treatment because we're not offering that treatment in the same way that we offer it to white people? And that, I think, is just, you know,
it's exactly those things. And the reasons though that happens is, you know, unbeknownst to us, there's so many forces that allow us as providers to have unconscious bias. We make quick judgments and quick assumptions about things. And when we're doing things quickly, when we're thinking about a lot of problems in the busy office setting, unconscious bias is a cognitive error. And so when we're busy and we're working fast and on cylinders, our bias is exaggerated. And so our quick decisions are often the root cause of some of these skipped steps. And the ways to mitigate that bias is have structured protocols where if someone meets that criteria, they get that treatment every single time, like that aspirin for MI. You know, that's one of the ways you mitigate that, right? You have a structured processes to mitigate our biases. The other thing we have, so that structural change can help our provider level, you know, lapses, so to speak. And the other aspects of this is the way we've designed our systems. And so some of the ways we've designed our systems have also set the stage for us to disproportionately offer that treatment to white patients as well, you know, irrespective of our micro level interaction with the patient or our trust, et cetera.
Having been a prostate cancer survivor,
Yeah.
early detection works really well. But in my case, essentially, not that my provider said this, but exposure to racism and the stress of having to deal with it in my job and being able to take a year off, nearly a year off, basically reduced the cancer by 80%, and it was slow growing in any case. So not everybody can do that, but I can definitely testify to the effect of not living in a food desert and having access to green space and other prevention, health promoting things that might not be available to a lot of other people.
Yep. We have 3 more minutes, and I definitely do have to drop off. If there's not any burning questions, if there is, that's fine. There is one slide here I thought I may want to show you. I'm not going to talk about the study, but basically it just shows you how we walked through trying to evaluate what was going on when we saw a significant wait time disparity between Black and white patients at one hospital that were both eventually admitted to the hospital. After accounting for everything, we still saw that difference. But one of the things that we saw that I thought was important to highlight was the role of naming racism. Naming race and racism is an intervention in and of itself. What we found was the only providers that when we unblinded the data, there was when we ask providers what may be causing, differences in wait times in your emergency room, et cetera, more generally, we didn't talk about race, we didn't talk about anything. The vast majority of providers we surveyed would name every demographic, but would not name race. They use sort of code words for race, or things that were maybe racially marked, but they avoided using race. And only 3 providers named race. One was actually named it to say, I don't think race is a problem, even though we didn't prime them to say that. The other 2 that named race named it in an appropriate way that said they believed that there was race-based differences. When we unblinded their personal panel data after that interview and looked at they were the only 2, the 2 providers that named race were the only 2 providers without their own personal wait time disparities for their panel of patients for the last year. And so it really highlighted the role that, naming race and racism can do. And so avoiding explicitly discussing race and ethnicity has been shown to reinforce stereotypes that are often inaccurate and exacerbate healthcare disparities. Strategic color blindness has been shown to worsen interactions between white and Black individuals. And explicitly recognizing race and ethnicity as a factor for influencing social interactions is a key prerequisite to applying strategies that have been shown to reduce bias, such as implicit bias training, perspective taking, etc. And so I end with that here because I think it's really important for us to just remember that we will not solve this problem if we don't name the problem. And so I think Ibrahim Kandi said, racism is the only problem that we're trying to solve without naming it, and it just doesn't work. And so we have to be a little bit uncomfortable enough to lean into this and say, it's okay. We are all byproducts of society that have drowned us in these biases. It's not any individual person's fault, and that we have to lean into this to figure out how to solve it together.
Thank you for that. That's a great place to end. Because a lot of times we are not necessarily willing to name the problem, and that's the problem. The concept of racism as a disease is older than me, and I'm nearly 70. And so you disagree with Einstein or Harvard, or what's the problem? Let's attack the problem. So thank you.
Thank you all. It was a pleasure being here. It was a pleasure being here with all of you this afternoon, and it was a lovely discussion. Thank you so much for your time. Take care. Bye-bye.
Go well, stay well.